It being 7 o'clock on the last Thursday of the month, first off, I want to welcome you guys all to our meeting tonight. This is a series of meetings that we do the last Thursday of every month. We've been doing this now for pretty much the whole year, even back into 2020. So it's been going really good. Looks like we have a really good crowd tonight. What we're going to be talking about tonight is concussions, and we have a very special guest with us. And I'm going to turn over to him in a second, but a couple of announcements that we'd like to talk about first is next month, September 30th, we will be having a pediatric panel. So a little bit different than what we've normally been doing. We'll have multiple guest speakers and multiple folks who will be presenting to us and answering your questions when it comes to pediatrics. A very good panel of folks who are very versed in pediatrics, so it should be a very good time. So watch for that email, probably coming out maybe even as soon as tomorrow or next week. I put in the request for hours today, so we should see those hours come through. Next thing, those of you who are ALS and need ALS hours, we've been having just a few issues getting ALS certificates, and we finally came to an agreement with the folks who issue those here today, and how we're going to get those out to you. So if you need ALS certs, put it in the chat or send me an email, and I have a running spreadsheet of who needs their certificates, and hopefully within the next week or two we'll be getting those out to everybody who needs those ALS certificates. Also, October 29th, 30th, and 31st in Pierre, South Dakota is the 2021 State EMS Conference. So please make arrangements to go to that if you are interested in going to that. I do believe there's going to be some sort of a virtual option. Actually, AHEC and Michaela are kind of handling that this year. So that'll be a good thing there. So if you're interested at all in going to the State EMS Conference, make sure you do that. Also, backing up just a little bit when it comes to getting credit for these classes, those of you who have not signed in to the EMS portal or BLS portal, please do so you can get certificates. There will be no paper certificates sent out. The state changed that a number of years ago, and there will be no certificates mailed out. It'll all be recorded on your state EMS portal. So for those of you who don't know what I'm talking about there, and need some help getting put in there, drop a chat letting me know that you need to be added to get your credit. Okay. We're gonna keep doing that for another couple of months, and then one of our trainings might be kind of a tutorial on how to do that. So if you have not signed up on the state EMS portal, so there's always two things you have to sign up for when you sign up for these webinars. You sign up for the link through AHEC, and then you have to go into the state EMS portal and sign up for the class. So if you have not done that, drop us a chat so we can make sure we get you credit. Otherwise, it's a little bit harder tomorrow when Michaela sends me the list of people, then I have to go off the list to make sure that you guys all got in there. So if you want credit for it, be sure to let us know. Going back to what we're talking about, the EMS conference, Northeast South Dakota AHEC is going to have a booth there, and we're also going to be talking about our webinars. So look for us there. And if you like what we're doing, make sure you are letting your friends know, letting your other people in your service know, so we can continue to get those things. And Casey just put a good thing in the chat. If you,
now what do I want to eat?
Let's make sure that we stay muted as well throughout the entire thing, unless our presenter asks for feedback, then we're going to go ahead and do that. But otherwise, please stay muted. The other thing, somebody just put it in the chat that if you are from out of state, then you need to get me your name as it appears on your EMS certificate and your EMS number and an email. So I can then send you a certificate, and then you can go ahead and do with that certificate whatever you can to try to get credit for it in your state. So we are a multi-state webinar. We have a few people joining us from a couple different states. So if you do need a certificate, if you're out of state, I'll only do it if you're out of state. So put it in the chat or send me an email directly, and I will put my email in the chat as soon as I get done talking. And send me an email with your name, your certification number, the state that you're from, and an email address so I can get that sent to you. Do we have any questions on that? All right, so I'm going to turn it over to our guest speaker tonight. I'm not going to try to pronounce his last name. I bet he gets that quite often. So I'm going to let him introduce himself. We're extremely happy to have you tonight, and take it away, sir.
All right, well, thank you for having me. I'm definitely honored to be here. So I am going to do my best to share my screen here. Hopefully I do this all correctly.
Looks good on our end.
Okay, and let me make sure I can, let's see. Okay, and we're off and running here. Okay, so yeah, so we are going to talk a little bit about sports concussions. To introduce myself, I'm Dr. Sam Schimmelfennig. I'm a pediatrician down here in Sioux Falls, South Dakota. Following my pediatric residency, I did a fellowship in sports medicine, and so I service our healthcare systems medical director for our sports medicine program, and I'm the team physician for some of the local high schools and the University of Sioux Falls. So see quite a lot of concussions. We're heading into football season, which means my number of concussions will go up, and definitely anybody who's on the sidelines is going to start to see some of this too. So I think a very, very timely topic. So the way that I'm going to approach this is to kind of start with some of the basics of, what does a concussion look like? What kind of things should we be looking for? Talk a little bit about how I approach the management of a concussion. So after it's already happened, what happens in the clinic, and how do we get these athletes or anybody back into their normal daily activities? And then a lot of my concussion visits nowadays, families have tons of questions. They read about lots of things. And so we're going to talk about some of those, I would say, high yield topics that come up on a fairly frequent basis. So that's kind of the general overview. I'll try to leave plenty of time at the end for lots of questions. So. And I'm trying to figure out why my thing does not advance the way it's supposed to.
If you click the next button on the bottom left of the screen, you should be able to use your arrows then afterwards.
There we go. Okay, thank you. So kind of concussion symptoms, they fall into four main areas. So what we call the migraine or the physical symptoms, that's typically the headache, the blurry vision, double vision, being sensitive to lights and sounds, nausea, vomiting, all that kind of goes along with that. They're very similar to migraine headaches. So that's how they get their name. The cognitive symptoms are really more of what they struggle with, especially in a classroom. Focus, memory, they don't always remember things. They might feel like they're in a fog. That's a pretty typical description that I'll get. Some psychiatric symptoms that they can get. A lot of times they're more emotional. They can be very irritable, especially in the days following the concussion, and their sleep can be off too. So they often have fatigue, but despite the fact that they're tired, they don't sleep well and feel like they can't fall asleep quite as well. And all these symptoms overlap, which has kind of several points. And part of it is that one athlete can have multiple symptoms in different areas, and no two injuries are going to be alike. So it kind of just gives you an idea of what some of the symptoms are, but also that they relate to each other, in that having a migraine can make it, or having a bad headache can make it hard to sleep, which can make it hard to focus in school, which can then make somebody very nervous about how they're doing in school, which then makes it harder for them to fall asleep, et cetera, et cetera. So a lot of these symptoms tend to feed each other as well. So when we manage concussion, it's kind of remembering that all these things relate to each other. So rarely is it just one thing that we need to do that sort of fixes everything else. So as things start, and this can be anywhere. This is more of a sports theme talk when I put it together. So a lot of sports references, but sports are not unique to concussions, or concussions are not unique to sports. So sideline evaluation is basically more of on the scene evaluation. So in terms of sports, whenever we're worried about a concussion, we need to pull them out. And sometimes that's because an athlete exhibits obvious concussion symptoms. They are acting confused, they run the wrong way, they're not lining up for their position correctly, something that's really obvious to everybody who's watching. But sometimes it's just a big hit. You see those sort of, I call them highlight reel sort of hits, or things that happen out on the field. And when we see that, as much as that might make people ooh and ah for the wow factor of it, from our standpoint, it's really like, boy, that could have been a concussion. That was a big enough injury. So even if they seem like they're fine, pulling that guy off the field and asking them some basic questions and screening them for concussion. So we'll ask what just happened. If you saw it happen, sometimes that's pretty straightforward. But sometimes they just come to us and say, I don't feel good. My head hurts. So what symptoms are they having, and what do they remember? The physical exam is very limited. It's not a whole lot we can do standing there on the sideline. So a lot of times it focuses more on what is their balance doing, what are some cognitive tests that we can do, looking at pupillary response, trying to assess their mental status. There are a lot of different concussion tools that are out there. The standardized assessment of a concussion, the balance error scoring system, the SCAT, the Sports Concussion Assessment Tool, which actually is in its 4th or 5th iteration at this point, King-Devick Testing. The SCAT actually combines a lot of these together. Not one of them is any better than any other. To me, it's more of having a system in place that you're comfortable with, that when we're worried about a concussion, how do we approach that? What questions do we ask? What things do we look for on physical exam? And then you have to decide at that point, am I worried about enough things that I need to call this a concussion, or that despite that being a worrisome hit that just happened, I think they're actually fine. So we have to make that call and then continue to monitor. So if we diagnose them for a concussion, we need to watch for worsening symptoms, which we will come to. And even if we end up thinking at the time that they're fine, concussion symptoms can evolve over time. So might not be there at first, but maybe 20 minutes later, maybe 30 minutes later, now they do develop symptoms. So checking in with them periodically, hey, are we still good, is a good thing to do. So when it comes to imaging, sort of when do we need to be really, really concerned? So definitely if anybody has a bad enough injury that they get knocked unconscious, if they actually have they have a pupil that doesn't respond, they have focal neurological symptoms. They looked pretty good early on, but now we are seeing worsening symptoms. Their headache is worse. Now they're vomiting. They were pretty clear cognitively, but now they seem more confused, where we're seeing a deterioration of their neurological or their mental status. Then that's falling into the emergency realm. So we need to get them to advanced medical care right away. A CT scan is typically the test that we would do in the ER, looking for evidence of skull fracture and intracranial bleed. We don't typically use MRI early on. And for either of these tests, if it truly is just a concussion and there is no skull fracture, there is no bleed, both of these tests are going to be normal in the setting of concussion. This is not an injury that you can see, at least on standard imaging. In the world of research, people do functional MRI scans, and we'll talk about that a little bit later too. Then you start to see some changes on MRI, but the stuff that we would order that are typically done on a daily basis, all of that's going to be normal. So if you're getting a CT scan, if you're getting an MRI, it's really to rule out something else, not necessarily to diagnose a concussion. So, I mean, I do lots of coverage in the fall, but definitely the vast majority of the concussions I see are my Monday afternoon sports medicine clinic, where the stuff from Friday and Saturday rolls in the door. So this is typically where we get a lot more of the information. So, and part of the evaluation is getting the story. It's like anything in medicine, a good history is the most important part of things that we do. So what is the concussion history? Not necessarily of this concussion, which is certainly important, but have they ever had a concussion before? How many have they had? And what is the story with all of those? Do they have any other conditions that are going to act like concussion symptoms? we think about the headache, and what we're trying to do is eventually decide when it's safe for this athlete to go back to their sport. We look for all their symptoms to be gone. But if they struggle with chronic migraine headaches and a headache 2 or 3 times a week is their norm, it's a little harder to then use headache as my criteria of, well, I think you're better because your headaches are gone. So knowing what other symptoms they might have that would overlap with concussion related symptoms is definitely very important. Same thing with their medications. I'm very happy if they took a dose of Tylenol and their headache is way better, but it doesn't really count because they took a dose of Tylenol. So I want to know if they're taking any medicines that might be masking their symptoms. From a concussion standpoint, the neurological exam and the mental status exam constitute the bulk of what we will do from that standpoint in clinic. And then we're going to talk about some of these other ancillary tests, a King-Devick test, balance test, and neuropsych testing. And I do a handful of these. These are the 3 tests that I should use. I say whether I do them all every single time, whether I do any of them, it all depends very much on the situation. So the King-Devick test has actually been around for a long time, and it was not originally a concussion test. It was developed by neuropsychologists, and it's more used in the world of things like Parkinson's disease and other degenerative neurological conditions. And so this test has 2 components. So this is just a card sort of isolating what it is, test 1, test 2, test 3. The first one is just a demonstration, but basically what they're doing is reading these numbers from left to right like they would read a book. And so as the reviewer, I have a copy of this as well. And so I am keeping track of 2 things. How long does it take from when they start the first test to when they finish the 3rd test? So their total time, and then how many errors did they make as they try to read these numbers? And so the first one's usually easy because they're literally just following the lines to each number. As the numbers become more scattered, it becomes a little bit more difficult to read the orders in the correct order. So the trouble with this test, the trouble with the best test, the trouble with the impact test that I'm about to go through as well. Trouble with all of these is that there is no score that is diagnostic of concussion, meaning that I can't say, well, it took you 30 seconds to do this, but norm is only 15 seconds, so therefore you have a concussion. What it really is a change from baseline. And unless we did this test at a baseline, we often don't have anything to make a comparison to. Not that you can't do it after the fact. You could do it again when you think they're better, and hopefully what we're seeing is some improvement. But what the goal of all these tests is to try to give us some objective data. Everything that the athlete tells us is very subjective. There's no way for me to look at them and me to know, do you really have double vision? Do you really feel nauseous? I might be able to pick up on dizziness, and I can pick up on some mental status confusion things in terms of their memory. But otherwise, I'm relying entirely on them to tell me their story. And so this is just an attempt to get some objective data. The best test, which is a series of balance tests, is another way to do this. And this is the balance error scoring system. It's 6 different maneuvers that the athlete would go through for about 20 seconds each. And our goal here is to check their balance while we take away all the normal ways that they would maintain their balance. So in the first picture here, the gal is standing with her feet together. So a narrower base basically versus a wider base gate with wider base, which is more stable. So narrower base, hands are on the hips, so she can't use her arms out for balance, and her eyes are closed. And those are our primary balance mechanisms. So we take those away and we see what she does to maintain her balance. And if she has to open her eyes, take her hands off her hips, those are all balance corrections. And we watch for 20 seconds. How many of them do you make? Most of the time, they're pretty good with this first one. And then they repeat it. They stand heel to toe, and then they stand on their non-dominant leg. And then you repeat them on an uneven surface. So I have a foam pad that I use for this. So they do them all over again. If you can imagine standing on your non-dominant leg on an uneven surface or a foam pad, these last 2 in particular are hard to do. So you want to have an assistant so that one person can really be standing there as a spotter, because we don't want them falling over and hitting their head again while we're trying to evaluate them. So one person can act as the spotter, and then the other person is watching the clock and then finding how many corrections do they make and just keeping track of what that total is. Again, you can't say that 5 corrections or 6 or 10 is diagnostic of a concussion. But what I will often find is that as I evaluate these guys, especially when dizziness is a big part of their presentation, we probably get somewhere around number 3 or number 4, where I'm to the point where as if I'm the spotter, I can't really take my hands off of them. Like they are basically going to fall over if nobody's there holding them up. And then when they come back later, when they're all back to normal, and I repeat these, and yeah, they're not perfect. No, I've yet to see somebody who can stand here like a statue in this final position, but they are at least doing most of the work on their own. They have to open their eyes to correct, but they can do that without actually falling over. So again, we're just looking for some overall improvement on that test. The impact test, probably what most parents are familiar with when it comes to concussion management. It has been sort of labeled as the concussion test. And most schools in the area typically will buy this software, and it has two parts. So the athletes do a baseline test. So sometime in their off season, they come take this test, which is done on a computer, 6 different modules that they go through. And then the computer tabulates some cumulative scores and then compares their scores to age and gender normative data to give you a percentile rank. So that's your baseline. Your baseline just sits there and doesn't have any use unless you get a concussion and you repeat the test. And then you're comparing to a baseline. And what the software does is now measure, well, what is your score compared to your baseline? And is it a statistically different change than what we've seen before? And if it's a statistically significant change, they highlight it as abnormal, and then you also get the percentile. So you can see in this athlete, they did their baseline. They actually got a concussion fairly shortly thereafter. And what we saw was his verbal score, which is some words that they need to remember, dropped from a 93 to a 66, which is a change from the 75th percentile all the way down to the first percentile. So a pretty significant change. And what we see over a couple of days as they repeated this test, they actually were worse several days later, which is a general observation that I've made, in that concussion symptoms typically do change over the first handful of days. And I have lost track a long time ago of the number of athletes who told me that they weren't so bad on Friday night, but when they woke up on Saturday and finally when I'm seeing them on Monday, they're way worse today than they were right after the injury. So the concussion symptoms can evolve as time goes by. One, this is an older slide. I mean, Impact has been around for a little while. I mean, this test was done in 2004. So this is an old example that I'm throwing up. Really, the only 2 points on an impact test that I actually care about are their baseline and then their final one. Whatever happens here in the middle doesn't really matter. With one exception that I'll talk about when I kind of talk about some of the limitations of this test. But this test, like our other ones, does not diagnose a concussion. So this athlete could have just had a horrible night's sleep last night, and maybe that's why these scores are going to be off. So it doesn't diagnose a concussion, and a lot of times it doesn't tell me anything that I don't already know. So when they come in and their scores are abnormal, and they just told me about everything that happened before I even looked at it, this doesn't confirm. Like, it just tells me what I already know. It doesn't necessarily it doesn't influence my, do I think this is a worse concussion or a mild concussion? It doesn't have any bearing on that at all. So the only points I really care about is this is where we started at, and now we're back to our normal, which would go along again with what I already know. So all of your symptoms are gone. Your exam was abnormal and now it's normal. And so this is just one more piece of that puzzle. And this was pointed out pretty well in the literature as well, which I think is probably this slide here. So I'll come back to this previous one, in that this is a very useful tool. It's a tool that you need to use a little bit to be familiar with some of the nuances I'm about to go through. But it can be very useful, but it's only one tool. It's only one tool in our toolbox, and it's not meant to stand alone. So whether or not you pass or don't pass your impact test, that's only one piece of the puzzle that we need to look at when we decide if somebody is ready to go back to their sports. This is a neurocognitive test. And ever since it came out, the volume of literature on impact alone is, even for a sports medicine guy, is hard to keep up with. And there's many sports medicine journals. The clinical journal Sports Medicine is one that I look at. It comes out every other month, or 6 times a year. And most of the time, at least a quarter of the articles in there are just on concussions. And a lot of times it's on impact, because it's one of the things that we can look at very easily. And what we found is that there's a lot of things that we need to keep in the back of our minds. This test that I just showed you was fairly close to, the injury test was very close to the baseline test, But in young people and adolescents, their brain is growing and developing very rapidly. So a question comes up of, well, how far away from your baseline can you still make that comparison? How long is it accurate for? Is it still an apples to apples, or are we now talking apples to oranges? Because you did your baseline 2 or 3 years ago, you did it your freshman year, and now you're a junior. Is that even really a realistic comparison? The one thing that, like I said, I think there's one situation in particular. I don't want to poo-poo impact. I think it's a great test. But the time that I find it most helpful is when I'm not entirely sure that an athlete is being honest with me. And I'm not finding anything on exam, but I'm sort of wondering that the fact that there's a really big game coming up in 2 days and they are miraculously better from a concussion that was quite symptomatic not that long ago would be, can I pick up on that? And that's kind of how the test is designed too. So if I have a markedly abnormal test, I'm going to be a little bit more careful about trying to decide whether or not I think this athlete is being honest with me. They have often a sort of vested interest in wanting to play. And so they might try to tell me what I want to hear so that I will let them play. Kids with ADHD, people with sleep disorders, all that will in fact impact a neurocognitive test. They take their baseline typically in the summer. They do their post-impact test in the middle of the school year, maybe at the end of the day or maybe in the morning. So the testing conditions aren't always the same. So there's a ton of stuff that we always have to bear in the back of our mind. And like I said, this was not meant to be a standalone test. It is perceived that way in the general public, but it really is just one useful tool of many that we would look at. So I'm kind of getting into the management part of concussions, and several sort of takeaways from this is that there is a general approach that we use for all athletes, kind of a general overhead picture, but it's actually very unique because every athlete is different. All of their symptoms are different. Even an athlete who has had multiple concussions might have different symptoms one time than they do the next. So it's a very individual approach. It focuses on the concept of rest, and that's physical rest and that's cognitive rest. But what that has also looked like has changed over time. And we used to recommend total rest. And so we would say, well, if your brain has been injured and we want you to get better as quickly as we can, you need to have rest. So let's just have you lay at home in a dark room, no stimulation. And that would be, we're giving the brain the best rest it can. And so it should heal up faster. And then as you got better, then we introduced physical activity. We would pull them out of the classrooms and did all this stuff, all in good spirit. This was our idea of trying to help them. But the brain is complex. If I can shut down a knee when a knee has been sprained, and rest usually is all we need to make it better, maybe a little bit of physical therapy. But the brain is far more complex than that. So it turned out that actually that wasn't the best thing. And so our concept of rest has changed. So from strict physical rest to modified activity rest, with an overarching goal of let's not get another concussion when you still have one. That's the big no-no. But you can be physically active. And in fact, if you are mildly physically active, the medical literature would show that you get better faster than if you were doing nothing. So as quickly as we're able to, usually within a couple days, I try to get them up doing some light, low intensity, low impact aerobic stuff, stationary bike, 5-10 minutes. Maybe they don't even go very long depending on their symptoms. We really ease them into it. But as they get better, we increase. So we try to get them moving right away. We try to get them into the classroom. At first when the athlete hears, oh yeah, I'm just going to pull you out of school for the next week, they're like, yay, vacation, hooray. And then they quickly realize that it's actually not vacation. School is still going on, even though they're not there. And the longer they're out, the harder it is going to be for them to get caught up. And so they start to sit at home, not being social, not being around their friends. Their identity as an athlete is now being significantly challenged. They're stressed out about school. None of this is actually helping their concussion-related symptoms. So we need to get them in school, but we need to modify what that looks like. And perhaps that is reducing the time that they spend in the classroom, giving them breaks, letting them turn off their computer and doing work on paper, giving them extra time to get their work turned in. All things that hopefully keep them in school, help them from falling far behind, allow them to continue to be social and interact with their friends, to reduce stress. All that stuff needs to happen, but we just need to adjust what that looks like. Medications, anything over the counter is fine. There's some theoretical worry that if you did an anti-inflammatory, which could affect your ability to clot, and you had a brain bleed, you could make that worse. I don't know that that finding has ever really been described in the literature, but I would say common wisdom is to stick with Tylenol for the first day or so. Obviously, if they end up in the ER and they got a CT scan and we know they don't have a bleed, then they're certainly fine with anti-inflammatories. Typically, by the time I see them 2 or 3 days later, the ship for an intracranial bleed has sailed. And really, as we know, probably within an hour or two, if we saw worsening symptoms, we should have seen it already. So ibuprofen's not necessarily bad, but I think common wisdom would be to stick with Tylenol. If they have any issues with sleep, melatonin is great, and we're going to talk about that in some supplements here in a little bit. And then rehabilitation, most of the time I end up not needing this unless we get into post-concussion syndrome, but focusing on physical therapy, if their balance is off of vestibular therapy, or if their vision is really off, we can actually send them for oculomotor therapy as well if they're having some of that blurry vision, double vision symptoms. So this is just that study I mentioned. So this was a trial a few years ago where in the setting of concussion, we would do strict physical rest. But if you got close to post-concussion syndrome, which was 3 to 4 weeks of symptoms, we would introduce exercise. And well, if we need to get you moving again, and then people would start to get better. And finally, someone asked the question of, well, aside from not wanting to get a second concussion, why are we waiting to allow them to exercise if we know that exercise is helpful? And so they randomized some concussions into 2 groups, one that got physical rest, one of them that got modified activity. And the folks that were getting some activity were better significantly faster. And that was pretty much the end of the whole strict physical rest. I might do that for a day or so while they're just feeling awful. But like I said, a goal is to get them doing some very mild activity, very low impact stuff, really as quickly as they can after their injury. Again, just to review, I have a letter that I send along for school. And this is where I have a whole, it's full of stuff. I check all the boxes, whatever it is they need, whether it's time to get their work done, testing accommodations, half days of school, full days of school. Again, that's going to look different for everybody. But whatever tools they need to help them in the classroom, we try to make that as easy as possible. Fortunately, this is not new stuff. I would say 10 years ago, I got a lot of kickback from schools when I would write these kind of letters. Like, what do you mean? He looks fine. Why are we doing all this stuff again? But I think concussions are so mainstream now, and I would say there's a fair bit of almost paranoia about them in some cases. It's rare that I have a school really buck me on this, unless it's ongoing and they see situations, which I've encountered as well, where the concussed athlete is happy and chatty and loves life until they get to math class, in which case they're all doom and gloom and need more time. So sometimes those kind of, the people try to milk the system a little bit, but for the most part, this seems to be very helpful and very well accepted by schools. Some of the therapy stuff, I got a little bit ahead of myself in terms of my slides, but physical therapy, focusing on the cervical spine. A lot of concussion injuries, there are sort of 2 parts of it. You hit the head gets hit often, and that's the direct trauma that causes it. But more often than not, it's the whiplash, it's the rotation of the head after the injury happened that causes probably more of the concussion symptoms than the actual injury itself, which of course can cause things like whiplash. So remembering to think outside the box. If we have a headache, what else could it be? And if somebody has got disorder of their cervical spine that needs to be addressed with therapy, then we need to make sure we address that. Vestibular therapy, if their balance is really off, convergence therapy for the double vision stuff. Sometimes I need a comprehensive, a more formal neuropsych eval. That's usually for ongoing symptoms where the school is looking at setting up an IEP or a 504, and they need somebody with a slightly different set of credentials. If they're saying, okay, well, if this needs to be long-term stuff, they tend to like a neuropsych to tell them, yes, we need to change how we teach this student as opposed to me. And totally fine. That is a neuropsych wheelhouse. So pain management, rehab medicine, occasionally this comes into play. Fortunately, 99% of concussions are going to resolve on their own if you just put the pieces in place. The brain is going to heal itself. We just need to allow that to happen. So our return to play criteria, what is our goal? What are we hoping for here? So in the short term, if you pull them from a competition and say you were diagnosed with concussion, you are out, take their helmet away, they are not going back in. I'm glad if they start feeling better 30 minutes later, they're still not going back in. One of the challenges that I often encounter is you hit your head and your head hurts. So does that mean that you actually have a concussion, or does your head hurt because you hit your head? In the same way that if you hit your arm would also hurt, but it doesn't necessarily mean that it's broken. So that is a difficult situation. And if there's any doubt at all, the mantra is when in doubt, sit them out. And it's not an uncommon thing that I run into. Somebody has a headache and they just hit their head. I have to err on the side of caution. I have to call it a concussion, and if they're totally fine by the end of the game and they feel fine the next day, I was wrong. And they can be mad at me for that. But I don't want them to be mad at me because I made a bad call and said, I don't think it is, and I let them play and something devastating happened. So I'll take the grief if it turns out it wasn't a concussion, because I have their best interests in mind. And as much as I love sports, these are young people, and I care more about the rest of their life than I do about the game of football or whatever that sport happens to be. So once you pull them, they are out, and they don't get to go back in until they are completely symptom free. And that symptom free needs to happen in several settings. So it needs to be at rest, which is usually the first one they get to. Then it needs to be with activity. And we're going to talk about the return to play protocol. So they need to basically be able to do their sport without having any of their concussion symptoms come back. And they need to be able to do their day-to-day stuff. So for the most part, that is school. Are you back in school? Do you need any of those academic accommodations that we put in place? No. Everything's back to the way that it was before. Good. So that's what I'm shooting for. So no symptoms in any of those settings. And then they do their return to play protocol. How long does that take? So for a young person, 10 to 14 days on average. But a lot of things are going to weigh into that. And that is the history part of things. And again, we can't make any definite predictions. There's not a necessary trend that always happens where each one over time gets better than one, or gets worse than one. Gets worse than the one before it. Sometimes you have a really bad one. And I've seen athletes where it took us 2 months to get through a concussion. And then, I hold my breath and I hope they never get another one. And then I see them on my schedule again 6 months later. And this time they're better in a week. And so just because you have a bad concussion, it doesn't necessarily mean that they will all be that way. You can have 2 or 3. There is no set number where at this point, okay, now we're going to start to see stuff start to get a little bit worse. So the return to play protocol that I mentioned. So it's kind of these are basically the stages that we go through, and this just gives you a general idea of how this is done. It does not have to be specific for. It can vary depending on the situation, is what I'm trying to say. So they start with this brief period of physical rest, which is likely more like a day or so, handful of days, maybe a week. But very quickly, we're going to try to get them to step 2, which is light aerobic exercise. So we'll use the example of a stationary bike, and it depends a little bit on how they do. If they have symptoms, and they get worse while they do the stationary bike, trying to assess what was it about the bike that did it? Was it the time that they spent on the bike? Did they crank up the resistance and go too hard? Was it in a loud environment? It was on the side of the basketball court and there were whistles and balls bouncing the whole time, and that's what caused their symptoms to get worse. So trying to look at the variables there. But as their symptoms get better and they're like, boy, I'm feeling better. What we start to do is then push them on the bike. Well, okay, you've been going easy on the bike. I'm glad you're feeling better. Let's push you a little bit. Let's go for a little bit longer. Let's try going for a little bit harder. Eventually, we just kind of keep inching our way along. And maybe that's a day, maybe that's a week. Every athlete's going to be different. I'm trying to do this every day. But then when they come in and are like, hey, I don't have a headache anymore. I woke up today and I feel great. And I've gone to school all day and I feel awesome. Like I have no headache. This was the best day I've had since my concussion happened. So once we get to that point, now they're symptom free, then they progress through the rest of the protocol, which is sort of a modified return to their sport. So, and this part is where it tends to look a little bit different, because this is really depending on what does their sport actually look like. So believe it or not, I've treated more concussions than I would have thought possible from members of the swim team. And swimming is an aerobic, non-impact sport done in the water, very different than what a football player would do. So I put a swimmer through a light practice, and then I have them do some sprints. And if they seem like they're fine with intensive aerobic activity, I'm going to go on the fact that they're fine. A football player, I'm probably going to have them do some drills, and then I'll have them put their pads on and do a non-contact practice. And then I'll have them put their pads on and do a full contact practice. And each one of these is a day. What we're looking for is sort of like after the injury happened, sometimes we see the concussion symptoms evolve. The same can be true in a return to play protocol where they felt like they were fine. And so we pushed them a little bit because they didn't have any symptoms. So we said, all right, well, we're going to go do some jogging and do some drills. And then by the time they get home, they don't feel good anymore. So you can have that delayed response, or the next day they wake up and they don't feel good. We know we pushed them too hard the day before. That's the point of that, the point of this progression. But generally, we try to give each one of these final steps about 24 hours between each one. So they don't do non-contact drills, go put their pads on and run a few plays, and then start hitting all within a short period of time. We do this for a day, we do this one for a day. They do their full practice, and then they're essentially cleared if they can do a full practice with no symptoms. You could also go longer. So if it took 2 or 3 months to get to this point, I'm probably not going to do in 3 days what it took 3 months to get to that point. So I might have them stick with non-contact drills for a week, just to kind of give them a chance to get back into a little bit of shape before they go back out there and onto the field. So this is a general approach. Schools and the athletic trainers that work there typically will put these together. So most of the time, this isn't always what I'm coming up with. I'm sort of sending the athletes back to their schools, and then the trainers are the ones that are actually putting them through this process, keeping in touch with me throughout as we need to, based on how they're doing. So some complications of concussion. Second impact syndrome is the big thing that we're worried about. This is why we don't put them back in, and this is why if I had to make a bad call, I don't want to make a bad call and have this happen. So this is a pediatric and adolescent issue. It's never been described over the age of 21. And we never really know for sure what happened, because unfortunately in second impact syndrome, the athlete dies. This is them getting hit out on the field, dropping to the ground, and rapidly dying from an increase in intracranial pressure. We don't know why. We don't know how long that window of opportunity is, but when it's happened, and it happens a handful of times every year across the country, when you look at game footage, what probably happened is we think the concussion happened here. The athlete showed no symptoms. They did not mention their symptoms. They stayed in the game and got a second injury very quickly thereafter, and that's when it actually happened. So it's a catastrophic thing. It's a huge tragedy. If you have any worries about a concussion, this is what you should have a fear of. And like I said, if parents are going to be mad at us, I would rather them be mad at me for being wrong, and their kid was actually fine. Post-concussion syndrome is the DSM-5 criteria. So at least three persistent concussion-related symptoms for at least 4 weeks following the initial injury. A lot of risk factors for this, especially their concussion history is probably the biggest one. But like I mentioned, there is no set threshold in terms of number of concussions that means, okay, your next one, we're going to end up in post-concussion syndrome. I've treated many over the years where this was their first concussion. And I've treated some that have had 7 concussions and still managed to get better after every one in a short period of time. So everybody is a little bit different. The trouble with post-concussion syndrome is you have multiple symptoms that are ongoing, and likely we need to have a multidisciplinary approach. If they're having a lot of cognitive symptoms, if they're having a lot of psychiatric symptoms, a lot of visual symptoms, we usually need to get a few more cooks in the kitchen at this point to help them get through this. Chronic traumatic encephalopathy is probably one of the biggest things that I now get questions about. And I get the questions about usually are twofold. One is, do I need to worry about this for my young athlete later on in years? Or is now the time to pull them from sports so that I don't have to worry about this later on in years? And so this is a neurodegenerative disease, and it's associated with repetitive head trauma. And this really hit the national news a few years ago, JAMA released an article where they had, I think, 200 old football players with signs and symptoms of CTE. And after they passed, they donated their brains to science. And what they found was, in I think 199 out of 200, they all had this, which of course then created an instant panic of like, boy, all these old football players all have CTE. But the thing to remember is that they all had symptoms of CTE. And so what that told me was that if you have a history of chronic head trauma and you have symptoms of CTE, a very high likelihood that you have CTE. It's only diagnosed on post-mortem exam, so there's no way to know about it for sure. Now, the things that we don't know about, and the way that I have to answer this question is, we don't know. So the problem is we are looking at athletes now who are treated very differently for a concussion than the way we treat our athletes currently. And so we won't know for 20, 30, 40 years, somebody will give this talk and they'll actually be able to answer the question. But I can't answer it now, because if I ask even people now, like, tell me about your concussions to try to assess some degree of risk for this, there's too much recall bias. We don't really know. Plus, we manage concussions differently. In the old days, people would play with concussions, and we don't let them do that anymore. So we're a lot more nervous about it. We're a lot better, I think, at managing it. So when it comes to young people, will we see less of this because we do a better job managing concussions now? Are they more at risk because they're younger when they're getting concussions? That's a great question. And again, one that we're not going to be able to answer for a while. But young brains seem to be a little bit more plastic. They adjust better to injury than adult brains do. So likely they would be at less risk. But again, we don't really know, and won't be able to answer that until we follow the athletes of today for the next several decades to see what happens. Disqualification from sports is a hard discussion to have. Anybody who's been an athlete knows how much time goes into being an athlete. And so when you have to sit down with them and say, it's time to be done, that's never a fun conversation. There is no, like I mentioned, there is no evidence-based guidelines. You can't say that three concussions and you're done. It's a nice euphemism for baseball, 3 strikes and you're out, but it doesn't really work for concussions. In 3 concussions over what? Over a season, over a year, over 10 years. So there's just so many variables there. This is a very individual decision. When it is more of a straightforward decision would be, say you got that CT scan and you found something you weren't expecting to find, that you didn't know was there, but now that you found it, you're glad that they're there, then okay, that's not necessarily the concussion that's disqualifying him. It's something else that we found because of the concussion. But when I see a trend where each one seems to be getting worse than the one before, again, that's no guarantee. Maybe they'll never get another concussion again. But it's a time to have the conversation. Or if you get to the point where you're now recovered from the concussion, but the new normal is not the old normal. So now I feel fine, but parents or friends say, you used to be a pretty chill guy, and now you're really, really irritable all the time. And even when you ask, like, I feel fine, and yet people around them are like, yeah, personality is not normal. So when something seems to be changing, to me, that is a sign that, yeah, you are recovering from these concussions, but the effect of these concussion is causing some other changes that we need to be concerned about. So when you see persistent post-concussive related changes, abnormal personality, that kind of stuff, that's usually when we start to have a little bit more of this talk. And even if we disqualify from sports, it's always important to know that we're not disqualifying you from all sports. But maybe it's just our full contact sport. So for the multi-sport athlete, maybe that's focusing on a lower concussion risk sport compared to a higher concussion risk sport. So so the CTE is kind of a common sports related concussion. And so at the end here, these are some of the things that parents have read about or heard about. And so these come in as, should I do this? I read about that. Somebody told me about this therapy. What do you think? So supplemental therapy like hyperbaric oxygen, and are there any blood tests that we can use to help? Doc, if you're telling me the neurocognitive test is not 100%, can we just do a blood test and find out if he's actually got this concussion, or check something like that? So these are probably the three common areas that I run to, and this is what I'll finish up on, then we can break for some questions. So omega-3 fatty acids used in lots of different things, but omega-3 in particular DHA is a huge part of what the brain is actually made out of. It's made out of omega-3 fatty acids. So thought is, well, if we have an injured brain and we give parts, basically give ingredients that the brain needs when it's fixing itself, then plenty of ingredients, plenty of construction supplies around it should help it fix itself a little bit better. The trouble with all of these supplements is they're all going to kind of run into a same sort of quandary where the literature is not definitive. And so people will look at this, okay, I supplemented all my post-concussive athletes with omega-3 acids and they got better. And people are like, oh, yay, here's something that we can do, wonderful. And then so people repeat the study. One study is usually not enough to make or break things. But so they do it again. And then the next guys are like, well, none of them got worse, but we didn't see quite the same benefit that you did. And so that's true with omega-3 fatty acids as well. There is some evidence that they help, some evidence in animal models that we haven't seen in human models. People have looked at timing. Should you take it before, like as a during season supplement so that you have less concussions or you recover faster? So there's tons of different ways people are looking at taking these, and none of them are definitive in terms of any actual neuroprotective effect or any really reliable difference in terms of recovery. Introducing exercise has kind of been one of the only things that's really shown to improve their recovery. Magnesium. So this goes back to my comment about MRI being normal unless you were doing a functional MRI, which is actually measuring brain energy and metabolism. And so what we'll see with somebody with concussion is that if you knew what part of the brain did math problems, for example, and you do a functional MRI while they do math problems, you see that part of the brain light up. And we know what parts of the brain do memory and do dizziness and help with balance. And so we have the athlete who's symptomatic and we do a functional MRI while we're stressing those parts of the brain and they don't light up the way that they're supposed to. So there's some decreased metabolic activity going on with the brain. And we see that that metabolic activity is partially driven by energy. And I didn't talk about the pathophysiology, like what's actually going on with a concussion. It's pretty complicated, but it involves changes in blood supply and changes in metabolism and energy use are kind of the two main pathophysiologic mechanisms. So energy in the brain comes from the mitochondria like it would in any other part of the body, and magnesium is a huge part of how mitochondria function. So we see on MRI that the brain is not functioning well. Perhaps it's an energy deficit. If we had more magnesium around, maybe a little bit more energy for the mitochondrial to function and less symptoms, less energy deficit. We have used magnesium in the pediatric world for chronic tension, chronic migraine headaches, and it seems to work okay for that. It might help with post-concussive related headaches. But again, we just haven't seen enough high-powered literature. Case reports, they're always great, but case reports don't necessarily extrapolate out to everybody. So another area people are looking at, there's tons of research going on with concussions. So maybe more on this to come, but right now it's something you can offer: omega-3 fatty acids, magnesium. These are things that I talk about with families. Like, yeah, if you want to try these things, you can, whether they help, whether they don't, just something that they can try. Melatonin helps regulate sleep cycles. Like I said at the beginning, messed up sleep is super common with concussed individuals. And so if we help them sleep a little bit better, that's when the brain is doing most of its work in terms of fixing itself. Perhaps they get better a little bit quicker. And so we have used melatonin for a long time for sleep stuff, and it definitely works great. For me, I think one of my important points I try to stress with families is to know what melatonin does and how it actually works, and that it's helping regulate your sleep cycle. It doesn't actually make you tired. It just helps mimic what happens if you have a healthy circadian rhythm and you go to bed around the same time. That's that I'm feeling drowsy around my bedtime kind of sensation. Your body is sort of like programmed to go to sleep around then, and it's getting ready to do that. So the melatonin helps mimic that. It needs to be taken about an hour before bedtime as part of a good sleep routine. If you're taking it randomly and you're going to bed at different times, it's not going to help quite as much. So they haven't really looked at it specifically related to sports related concussion, just in sleep issues in general. So again, another area of active research, trying to, focus specifically on sleep disturbances and concussed athletes and the benefit of melatonin. All three of these, as long as you're taking them within the prescribed dose, which for little kids, I often end up looking up because we do a lot of weight-based dosing in pediatrics, and I can't keep all these medicines straight in my head. There's just too many of them. So I look them up, and as long as you're doing an appropriate dose, there generally isn't any side effects. So again, first tenet of medicine, first do no harm. So I don't have problems with people trying things that may work or may not work, as long as they don't have any potential to do harm. Hyperbaric oxygen. So this is kind of an interesting, and I think hopefully maybe upcoming modality that might start to have a little bit more use in the world of especially post-concussion syndrome. It has been, I mean, hyperbaric oxygen typically for, pressure related things, diving injuries and stuff like that, gets used for wound care management, especially nowadays, different neurological conditions. So it's kind of been around for a while. It's been used for lots of different stuff. And up until recently, the literature was sort of, well, we don't really know. We've never really specifically looked at it in terms of sports related concussion. So there was a meta-analysis a few years back that recommended more research. And so this study was initiated. So there's the National Brain Injury Rescue and Rehabilitation Study. So this was the kind of thing that we really want if we're going to look at an intervention that we're going to extrapolate and say, yeah, this works for everybody. So yeah, a multi-center observational study involving males and females in the right age range with a history of traumatic brain injury post-concussion syndrome. And their goal was several-fold. So A, does it work? Does it work? Does it not work? And because hyperbaric oxygen has tons of variables, meaning how much pressure and how long do we want to stay in the chamber, to try to come up with some sort of, how do we do it? How many times? And so they had 32 subjects, 48 enrolled, 32 actually completed it. And they had an algorithm they followed from 40 to 80 1-hour sessions at 1.5 atmospheres of pressure. And if they were better at 40, they were done. If they still had symptoms, they went to as many as 80. And then they measured all the outcomes that we would measure. And sure enough, they got significantly better. So their mood scores, and the black is their symptoms before therapy, and the white is after. So sleepiness got better, restlessness, depression, anger, fatigue, anxiety, happiness improved, vigor improved. So pretty much most of their mood measures got better. Their neurocognitive measures, so their short-term memory recall, I can't remember what these all stand for, but everything all got better, which to me is like, okay, we have an intervention. We do need to be careful because it is possible to cause some harm. So you need to have somebody who's trained in hyperbaric medicine to be administering it, but it seems to work pretty well for these folks in terms of helping their symptoms, especially because other than physical therapy and the various rehabilitative modalities, we are kind of stuck. We don't have a lot of great things. So to me, this is a new and upcoming tool, and hopefully we will hear more about it in the years to come. So some other things they found, earlier treatment seemed to be better. The younger they were, the better it seemed to be. And not surprisingly, with a lot of things, the more times they got treated, the better they tended to do. So with every study, we find answers. We probably find more questions than we just ended up answering. And so this study, some downsides to it. It had a large age range. A lot of these were not necessarily sports-related concussions. This was is primarily funded by the military. So a lot of veterans with blast-related injury, blast-related trauma, sometimes large amounts of time, years between when the injury happened and when they entered the study. And there were no children and adolescents. So for my world, my college kids are over the age of 18, but the vast majority of young adolescents that I've seen, they don't fall into who was actually studied in this procedure. So these are some of the questions that came up. Is it safe for children and adolescents? We never assume anything, probably, but we don't know for sure. What is the ideal time? They were in there for an hour at 1.5 atmospheres. Could they have done 30 minutes at 2 atmospheres? Did they need to actually do 40 sessions? And would that vary if you change the pressure and you change the time? Would that affect the number of sessions? Does the cause or the nature of the injury or any symptoms that they have seem to be relevant to whether or not they would qualify? And because it's still going to fall under the realm of basically experimental therapy, it's not going to be covered by insurance. So unless you have a grant or something to be studying it, we don't really have a lot to essentially recommend this for patients yet. But I think it's something that's potentially going to probably we'll see a little bit more of in the years to come. Certainly, the results from this big study were promising and encouraging enough that will hopefully spur a little bit more research. So the final thing, what I like to call the holy grail of concussions, would be serum biomarkers. Tons of people are looking into this because this will really make things a whole lot easier. A rapid test that you could do on the sideline, get a drop of blood, run it through a quick machine, get a quick answer that's going to give you a yay or a nay. Nope, he doesn't have it. He is good to go, or his markers are elevated. And so there are, with anything, lots of questions. So there are many, many biomarkers that people are looking at. Are any better than any others? What about the timing? Does it matter when you drew that marker versus the information you're hoping to glean from it? What about age? What about gender, ethnicity? Does any of that bear any relevance when you look at the answers? And would it make any difference in what we end up doing? Does it actually help us diagnose a concussion or not? So these are several different studies. These are all concussion-related serum biomarker studies, and they are all illustrating several points of why, as much as I think as it would be a huge and wonderful thing, I struggle to find any hope that it will become a reality. And this is part of the reason. So this was a study. All of these looked at many, many biomarkers, and only some of them were statistically significant. So this is tumor necrosis factor, fibroblast growth factor, interleukin 7. And what they were looking at is how these levels changed in related to concussion. So the H is when they were healthy. The second was when they got concussed. The third was if they actually had a repeat concussion. And what we're starting to see here is that this was the normal range for subjects without any symptoms. This was the normal range with concussion. The range was different with repeat concussion. This one basically didn't change so much. The fibroblast growth factor didn't change so much acutely, but if you had a repeat concussion, it got downregulated. For some reason, it was lower than normal, but not when you had the first concussion, only when you had the second concussion. This one became upregulated. So we saw more interleukin 7 in the setting of repeat concussion. And this one was downregulated early on. So they kind of a huge range there. The upper limit of normal didn't really change, but the lower limit dropped down significantly. And then when you got repeated, it went up. The lower limit went up significantly. So what this tells me is that, yeah, whether it's your first concussion or your second, you have to be careful about how you are interpreting that number that you're getting. This was one where they looked at the same one over a period of time. And again, I don't remember what these all stand for, but anyway, doesn't really matter. So this was when they were healthy. This was 1 week. This was less than 1 week, greater than 1 week. And so this one is downregulated throughout the course of a concussion. As time went by, the levels got lower and lower. This one actually went up. This one stayed about the same, but a little bit of upregulation and then a little bit less later on. So timing is making all the difference in terms of how we're interpreting the answer. This study looked at basically just baseline. And so these were college kids. They looked at, again, many of them, but these were the two that got published in the study, and they were healthy. These were college athletes in their off season with no reported symptoms of concussion. And all they wanted was baseline. And they wanted to see, well, what kind of numbers do you get in terms of baseline variation? Specifically related to gender and ethnicity. So this UHCL1 and SB100. So between Caucasian and African Americans, huge difference for both of these in terms of your ethnicity. Just baseline. This was gender. So male, female, huge range there. So one more thing, depending on which one you're looking at. Oh, do you need to have different normative data based on that? So, and again, none of these were age. That's probably the final variable about, well, does a 7-year-old, does a 10-year-old, does an 18-year-old, do they have different normative data? Couldn't find any good graphs that kind of showed that, but I would say potentially. So as much as I think that it's a promising area of research and a lot of time and money is being poured into it, because it certainly would be financially lucrative if you were able to be the one that kind of came up with the test. So people are looking at it, but I think that those graphs hopefully illustrate some of the challenges that are going to come when it comes to actually using these biomarkers in a clinically relevant way. So still a lot more research that needs to happen, and tons more information in terms of the normative data. So I will finish up and take some time for questions here, but kind of hopeful take home points. That kind of first slide in terms of signs and symptoms of concussion, know that they can evolve over time. So if you have an athlete who you diagnose or you think is cleared and doesn't have one, checking in with them periodically to make sure they're not getting worse or they're not developing symptoms that weren't there early on. Recovery is unique. Every athlete is going to be a little bit different, but we kind of want to have the same overall approach, and that is, let them do life, but we need to modify what life looks like. We want them to be physically active, but we need to modify that. We want them to be in school and still do fun stuff and still be social, but we need to make sure they're not in situations where they could get another concussion, or in situations where they're actually making their symptoms worse. So they need to do that return to play protocol. I always love it when somebody comes in and tells me they're symptom free, but if they come in and tell me they're symptom free and they want to play in the game tonight, my answer is, you're not quite ready. We still have a couple more days worth of work to do before we get you out, back out there again. And if you have any doubt and you're not sure which way should I go, I'm not sure if this is a concussion or not. If you're not sure, it's a concussion. Treat it like a concussion. So that is all I have. I hope everyone kind of found that useful. A little bit of good information there. And like I said, I will pause for some questions.
Well, thanks very much. Before we open it up for questions, there is one thing that we need you to do when you're all done, so nobody jump off. There's going to be a survey that pops up, so make sure you fill out that survey before you log off. So anybody have any questions? You can either ask them, you can unmute and ask them, or you can go ahead and put them in the chat. We'll monitor the chat box. I guess I'll start it off with one. Do you ever get pushback from your coaches or parents? And how often do you get that?
Yeah, not so much from the coaches. In all honesty, I remember when I started my sports medicine fellowship, that was one of the things I was worried about. Actually going to a Division I program, big guys, big stakes, and here I am, a former swimmer, 150 pounds maybe if I'm soaking wet. And what am I going to look like if a 300-pound strength coach gets up in my face? And so I asked my fellowship director that on my first day, like, if I think that somebody has a concussion and they need to go out, like, is that like, how will they respond to that? And he was like, you will not get any kickback. And I can say that I don't know that coaches are mad. They're always mad when somebody comes out, and it doesn't really matter whether it's a concussion injury or a knee injury. They just lost one of their players. But I've never had a coach be mad at me for pulling it, because I think as much as they care about the game, they also care about their athletes. So, and just given to me, I would say the medical legal ramifications of somebody, of me saying they are out and then the athlete going in and something happening. No, I have not gotten any pushback from coaches, fortunately. I will say that, so I've been on the sideline now since 2004 is when I first started covering stuff as a resident. And early on, so our concussion, like how we manage concussions, has really changed over time. And so early on, this whole if in doubt, sit them out, this whole you need to rest until you can't go back in. There was a time where I used to carry around this card and it had a list of symptoms on it. And if you didn't have this or that, you could go back in 30 minutes. Or if you had this or that, you could play the next day. It was very arbitrary, based on kind of expert opinion, but very arbitrary and clearly based on what we know now, not a good way of doing things. But that for a lot of parents is what they were familiar with. And so when we changed and said, you know what, it doesn't really matter what symptoms you have, a concussion is a concussion and you are out. So that first couple years of me pulling athletes out, yes, I had a lot of parents get in my face and say, well, what do you mean he can't play? I played with concussions all the time. Like, it's not that big of a deal. And as time has gone by, it has really been years since I had a parent be upset that they're pulled. Like I said, if anything, I feel like the pendulum has swung the opposite way, where I now have parents who come to me in clinic and say, do you think that he should continue to play football after one concussion? They're that worried about the long-term effects of concussion that they're almost like the opposite way, like we shouldn't play sports anymore because of this. Or do you think it's still worth him playing? And it becomes a fine line. Like, I've had parents like ask me to disqualify their athlete, and it becomes a little bit dicey because I don't have any medical justification for doing that. And so if they were to go seek a second, the athlete seeks a second opinion from another sports medicine guy, they'd be like, what was Dr. Sam talking about? Like, he knows better. There's no reason why you couldn't be playing. And it makes a little bit of an awkward situation. So I just, it's more open conversation and everything has risk. But to answer your question, no, I do not get a lot of kickback anymore from coaches, from parents, from school administrators. Early on, whenever you do something new, people are, you adjust to the change. And so you get kickback then, but as it becomes more norm and people are used to it. Yeah.
Great. There was one that came in on the chat when you were talking about the hyperbaric oxygen therapy. The question was there a control group or was there not a control group in that study that you had pointed out?
Nope. Good point. There was not a control group. So there's a few other studies about hyperbaric, and that was one of the criticisms that they came up with, is that there was a study, and I can't remember the specifics of it, but they had a control group. So they had people that were getting therapy and things that were getting sham therapy. But even their sham therapy, they weren't able to totally do nothing because the patient would be able to tell that, because your ears pop and stuff like that. So they still had to do some sort of pressure, even though it was not nearly as much as what the people in the treatment group were getting. But that was the criticism that a lot of people had of that paper, is they didn't really have a sham. They were all being treated. They were just being treated at different pressures. So it would be hard to do a true randomized group for that reason. I mean, you're changing your pressure, so when you're in there, that either something's happening around you or it's not happening.
Sure. Anybody else? Any questions, comments, concerns? Either put them in the chat box.
It looks like someone sent me a chat that says, if swimming is a high concussion sport, what are some low concussion sports?
I am a former swimmer, so I can make fun of myself a little bit in that we're not very coordinated on land, I guess. And so no, swimming by itself is not a very high concussion sport. We were just not very coordinated and hit our heads. These athletes, they fell in the locker room, hit their head on the bunk bed in the dorm. Totally random stuff. So yeah, I was joking there. But yeah, concussion would be low risk in swimming. I've treated a golfer who was in the wrong place at the wrong time, got whacked in the head. So I feel like there is nothing in life that we do that does not come with some degree of risk when it comes to a concussion. And sometimes they're not even athletes that I'm seeing. We slipped in the parking lot on some ice in a South Dakota winter and hit our head, or got a motor vehicle accident or something like that. So everything always has risk. But there are certain activities when you are intentionally running into each other that are going to be higher risk. So your wrestlers, your football players, your ice hockey players, all those are going to constitute more of your high risk sports.
Anybody else? Any questions, comments, concerns? So, like, what is your normal caseload, I guess, as far as dealing with people with concussions? I mean, does it obviously pick up this time of year because we're into football, carry right into basketball, hockey, things like that? Is it?
Yep.
a lot higher this time of year, or do you still see quite a few over different
Yeah.
times of the year?
Yeah, great question. I mean, I see them all year round, but football season is definitely I would say the high point of the year in terms of concussions. Basketball season, surprisingly, is not that far behind. And I think it's just because the game of basketball is a lot more physical now. Guys get knocked down basically and hitting their head on the court. So, but yeah, football, and some of it is we have to look at the number of people in the sport. So a whole lot of people play football. Like if I feel like even small schools have a football team come the fall. So quite a few athletes, and then not as many of them are going to be playing basketball. I mean, even if you have a basketball team, you got 10 guys maybe on the team where you might have 60 or 70 guys on your football team, all of who practice and they get concussions in practice too. So fall is the big time. I see them throughout the winter as well. They happen all year round, but fall is the busiest. On an average week, I probably average 5 to 6 a week. The most I've ever seen is 13 or 14 in a week. So it just varies.
Sounds good. Teresa, did you have a question? I see your hand was raised on your little box. If you have a question, just go ahead and unmute.
For herself in the middle of a walker attack. So
I was wondering if you're on an ambulance call and they bring an athlete over to you, who has that authority to pull that athlete from the game?
When they have the chance. On tonight's show, we have interviews from the
Yep.
set of behind the scenes.
To me, I think if you're looking for more of a hierarchy question, I would say whoever the most trained medical person is there should be able to, essentially they're the highest up on the food chain. So, and I don't know when for a EMT versus a nurse, like, people are probably going to argue who has the most experience there. But I think if anybody has any worry, it's always, what is the worst case scenario? You pull somebody and they don't have you pull somebody and they don't have a concussion and they turn out to be fine. We're all glad that they're fine. And like I said, I'm not upset that I made the wrong call there, because I don't want to make the other wrong call. But ultimately, that might actually even vary based on the situation. And some schools might set that up and say, you know what, it is the coach who has the final call. Perhaps it's the paramedic who's on site. Perhaps it's the medical volunteer who says, hey, I'm going to be your medical, kind of medical contact on the sideline. Smaller towns, yeah, it's probably people in the community that volunteer for that sort of role, EMS personnel. For me, I mean, most of our big schools, we always have a doc or two on the sideline. So typically an orthopedic surgeon and one of the primary care sports guys like myself. So I typically make the concussion calls, and the orthopod makes all the bone calls. And we're happy to give each other those jobs. But I don't know that I have a good answer for that. But like I said, I think the most important thing is that people need to be aware of what symptoms of concussion are, and if there's any doubt, then we just need to make that known, and not let them play.
I think I could probably piggyback on that answer a little bit. And Teresa, you said it. They brought them to you to be looked at. At that point in time, now you are the provider. You are providing care to that patient. And if you find those different symptoms, then at that point in time, you would have that call. I think the best way to do this is to probably have that conversation, like Dr. Salmon mentioned, is open those lines of communication with your coach, with your school administration, whoever. And, maybe it's one of those deals where 2 or 3 of you get together and say, here's what I saw, here's what I saw, here's what I saw. And you all make that decision like, okay, this kid's probably got it. So a couple other questions that are flying in on the chat box. Do you treat many rodeo athletes?
I have never had the pleasure of treating a rodeo athlete, but to me, it doesn't really matter so much how the concussion happened. A concussion's a concussion, and whether they're an athlete or not, it's the approach is the same in terms of how their symptoms are managed, and then probably a little bit unique from a rodeo guy, in terms of how you get them back out doing their sport. But at the end of the day, the first step and the step that we need to get to is they need to be symptom free. So once they're symptom free, then we can look at like, okay, well, how do we want to get you back up riding a bull? I think it's one of those things, you're either doing it or you're not doing it. So we just need to be pretty comfortable if we're going to put him back out there that he's not at risk for having anything worse happen.
Great. Another one that came in from Jeff, in your opinion or an experience, what does a good sideline exam consist of?
So the big things I do on my exam is talk to them. Hey, how are you feeling? What symptoms do you have? Ask them specifically about things. Do you have a headache? Do you feel dizzy? Do you feel sick to your stomach? And then in terms of the physical exam part, I look at pupils. Do they have a good pupillary response? I do extraocular movement testing. So I'm watching how their eyes track, looking for a lag. If my finger gets over here and then it takes them a little bit to catch up, or they seem like they're having a hard time focusing. The old school concussion test, like, hey, how many fingers am I holding up? That's that blurry double vision thing that comes from two independent cameras that are not working together anymore. They are working independently. And that's why you're now seeing two of things, why you have the blurry or double vision. So eye related stuff, that's typically what I can do. Balance is a little harder to do. Part of the reason I find that it's hard is, especially for football players, they usually have cleats on. And depending on what the surface looks like, I try to get them off the field, because otherwise they're burying their cleats in the ground. They're going to be pretty stable standing right there on the turf or in soft ground and cleats. So try to get them on something that's a little bit harder, so I'm not like, oh yeah, this guy's balance is actually terrible if I get him on a hard surface. And then I have a series of, I just memorized a list of 6 random things. So if athletes know me really well, they know what my list of 6 things are. But I do a memory test. So hey, I'm going to say a list of these things, repeat them back after me, and I see how well their short-term memory and how well their concentration is doing. I'll ask them orientation questions like, hey, where are we at right now? What period of the game is it? What quarter is it? Who are you playing? What number are you? And surprisingly, I've had guys look up at the scoreboard because they don't remember what quarter it is or what the score is, or what their own number is. So, kind of like, to me, like simple questions, but if they are struggling to answer them, that is a sign to me that, yeah, as we say, the wheels aren't all turning up there the way that they're supposed to. So that's pretty much the majority of my sidelines. Kind of a couple mental status questions. Where are you at mentally? Some balance questions, some eye related stuff, and then what they tell me in terms of their symptoms.
Sure. Great. Thank you. Anybody else? Last chance. All right. Well, while Michaela goes ahead and puts up the survey, that was fast. Again, these webinars are brought to you by Northeast South Dakota AHEC, District 4 EMS, in conjunction with the South Dakota Community Foundation. So we thank all the folks involved there. We also want to thank Dr. Sam tonight for giving us a fantastic lecture and talking to us about concussions. I know I really enjoyed it. If you enjoyed it, go ahead and put some things in the chat box. We're very, very happy to have you. And hopefully we get you back again sometime to talk to us again about some things. So thank you very much.
Yep, I'm happy anytime. So yeah, once again, I appreciate it. And yeah, have a good night, everyone.
Thank you.
Thank you.
Be sure you are answering the poll, please. And after you've answered